All right, we're talking about the respiratory system today. Um, so, this is going to contain information that links to the cardiovascular system. Remember, the cardiovascular system transports the blood so that it can drop off the oxygen to the tissues, pick up carbon dioxide. So, some of this is going to be a recap, and some of it's going to be new based on the specific function of the lungs. By and large, the story of the respiratory system is the story of oxygen and carbon dioxide. So remember, oxygen is required to do a lot in the body. Break down nutrients, it releases energy, and produces ATP. Carbon dioxide is the byproduct of this. So it is the waste created by nutrient breakdown, which ultimately has to be expired from the body. Respiration is concerned with the method by which an organism produces energy. So even though we talk about breathing in oxygen, breathing out carbon dioxide, all of this is to ultimately bring in the resources needed to build energy, and pushing out the waste as a byproduct. So the respiratory system itself obtains oxygen from the atmosphere. It removes carbon dioxide from the body cells. Yeah, it is basically a filtering system of tubes that can warm the air, moisturize it, and transport it into the areas of the body where the gas exchange happens in these microscopic sacs called alveoli. The big thing here is I just want you to understand that oxygen is necessary to create energy, release energy, and break down nutrients, and carbon dioxide is the waste product that is created. So therefore, respiration is really the story of energy production. So there are three stages of respiration: external, internal, and cellular. External respiration is the ventilation of breathing, right? So it is the exchange of the gases between the air and the capillaries of the lungs. Internal respiration is the transport of those gases to the blood so that they can then exchange it to the tissues. Cellular respiration is the use of the oxygen in the tissues to create energy and therefore create the byproduct carbon dioxide. So with external respiration, we're talking about bringing air into the lungs so that they can enter the capillaries of the lungs. Internal respiration is when it's inside the capillary of the lungs, it goes into the blood, then the cardiovascular system happens where it drops off oxygen to the body cells, picks up carbon dioxide to be breathed back out. And then cellular respiration, which we won't really get into in this class, that is the production of energy and carbon dioxide inside the cell's mitochondria. When we talk about the respiratory tract, we're talking about the upper and lower tract. In class, I talked about how it's mostly epithelium in the upper tract, and then the lower tract, it's predominantly cartilage. That's not to say that there isn't cartilage in the upper tract, specifically the larynx, but in the lower tract, it is predominantly cartilage before it enters the lungs. So upper tract is going to be the nose, the nasal cavity, the sinuses of the skull, the pharynx, the larynx. And then the lower tract is going to be our trachea, the bronchial tree, which then penetrates the lungs, bringing the oxygen into the lungs themselves. So make it easy, memorize the lower tract, know that everything else that makes sense as a part of the respiratory tract, therefore, is the upper tract. Here's a visualization. So again, this is very like soft, squishy epithelium. Nose, nasal conchae, the sinuses, the pharynx, the larynx, and then the trachea, the harder part made of total cartilage, the bronchial tree, and then again, the squishy part, the lungs. So nose, the big things here, it's got two nostrils. It has a nasal septum, which divides the nostrils. Yeah, it's a feature of the face, supported by bone, predominantly cartilage. All right, this is our nose breathing, right? There are coarse hairs, which prevent entry of particles. Again, when we're talking about cilia or any of those kind of hair-like things, what we're talking about are ways of trapping bacteria or other pathogenic bodies so that it can't get inside the body. It's a protective immune layer. Yeah. Inside the nose, we have the nasal cavity. It's our hollow space divided medially by the septum, right? Inside that, we have the nasal conchae, or rather, I should say, deeper to that is the nasal conchae. Basically, it divides the nasal cavity into three passages: the upper, middle, and lower. The nasal conchae really just warms, moisturizes, and filters the incoming air. Now, the nasal conchae is where our mucus is created within that nasal cavity. So when we talk about mucus, of course, we mean goblet cells that secretes the mucus. And it also contains cilia, which is going to be that wave pulse of small hairs to push things back out or to bring them in. And the way it basically works in the hair of the nose is sometimes it'll push things out or trigger a sneeze. Sometimes it'll pull it in via the mucus, and instead of bringing it down the air pathway, it'll bring it into the esophagus, where once it enters the stomach acid kills any pathogenic material. And again, because it's a mucous membrane, it is pseudostratified, ciliated, I'm going to add columnar epithelium. Remember, the only pseudostratified epithelium in the body from our tissues unit is columnar. So it's going to be ciliated, which means it has cilia. So again, here's the nose. We have the nasal passage. The septum is that in-between part. All of this is the nasal cavity, and that contains the nasal conchae. Yeah, superior, middle, inferior. Okay. This will then enter into the pharynx. Again, it's pseudo-stratified columnar, so we can see it looks like multiple layers, but it's really all one layer. Here are little goblet cells. They secrete the mucus, and here is our cilia, which basically captures the particle in the mucus. The cilia pushes it down into the esophagus, where once it enters the stomach, is destroyed by stomach acid. The paranasal sinuses. There are 4 paranasal sinuses. Para meaning around, nasal being the nose. So sinuses around the nose. The big ones I want you to know are maxillary, that's your cheeks, and frontal, that's your forehead. Ethmoid and sphenoid, those are inside the skull. Now the sinuses all open to the nasal cavity. They are an empty space, which makes them a potential space for infection. So when you have a sinus infection, that sinus congestion you get is pus filling these spaces, creating pressure in the skull. The purpose of these spaces is to help with resonance. So it creates a resonant chamber for your voice to be created, as well as reduce the total weight of the skull. So going back here, we have our frontal. We have our sphenoidal. I'm looking, we do not have our ethmoidal, and here about is where the cheek would be, and that would be our maxillary sinus. Pharynx. So again, once we exit the nasal conchae, we enter into the pharynx. The pharynx is the space behind the oral and nasal cavity. So again, oral nasal cavity, here's the pharynx behind it. It is a common passageway for air and food. So it is a junction point where the oral cavity and the nasal cavity combine. And it is a common spot for food and air. So once we hit the larynx and then divide into the trachea, it's air only versus going down the larynx and then into the esophagus where it's food only. Here we have both of them. It aids in producing the sound for speech. I'm not worried about you knowing this, but there are 3 subdivisions: the nasopharynx, the oropharynx, and the laryngopharynx. Nasopharynx is right here. It's where the nasal passageway enters the pharynx. Oral pharynx is as it enters here, where the mouth, the oral cavity combines. And then laryngopharynx is where it turns into the larynx as we continue lower. So the laryngopharynx here has the epiglottis And what happens is it then either goes down the air pipe, which leads to the larynx and the trachea, in the front here, or it enters the esophagus in the back, okay? The larynx, the thing I want you to know here is this is your voice box, okay? It is going to contain your vocal cords. There are 3 cartilages here. Yeah, there's the thyroid cartilage, which is what we call the Adam's apple, more visible generally in biosex males. We have the cricoid cartilage, which is a little lower, and then we have the epiglottic cartilage, which is posterior. So looking at it from the front, we have the thyroid cartilage, looks like a little bit of a butterfly's wings. The thyroid gland lays right across there, is often described as a butterfly-looking organ. We have the cricocartilage a little lower down here and slightly posterior. And then as a fin, we can see it better here from the posterior side, we have the epiglottic cartilage. And then we enter the trachea. So here's the back, thyroid cartilage, cricocartilage, epiglottic cartilage. So in the larynx, when we're talking about the vocal folds, there are 2 vocal folds. Okay, there's false and true. Yeah. So 2 pairs of vocal folds consisting of muscles and connective tissue that cover with the mucous membranes. The upper pair is called the false vocal cords, which does not produce sound. That's why they're false. And then the lower pair is the true vocal cords, which actually does produce sound. The glottis is the opening between the true vocal cords. So the false vocal cords are more lateral. They connect to the true cords, and the opening created by the true cords is called the glottis. When we breathe, the vocal cords relax and the glottis opens, air travels through. The changing of tension on the vocal cords produces the pitch of sound. The force of air going through the glottis produces volume. So, again, loudness depends on how much air is moving through the vocal cord, and then how much tension controls our pitch. So the pharynx, the oral cavity, the tongue, and the lips then transform the sound into words. So, when we're talking about how our voice is produced, air coming from the lungs goes up through the larynx, passes through the glottis, which is the hole made by the opening of the vocal cords. How much air is being pushed through there, how fast, determines our volume. The tension on these cords and the opening shape creates our pitch. Once it then goes up the pharynx, the oral cavity, the tongue, and out through the lips, all of that modulation of that wind creates sound that we then call words in language. The epiglottic cartilage makes up a flap-like epiglottis. So normally the epiglottis stands vertically, allows air to enter, but during swallowing, the epiglottis closes off the glottis to prevent food from entering the larynx. So let's go back to that picture. Again, when we're breathing, it's nice and vertical. Air comes in here, goes down. Air comes in here, goes down. When we swallow to swallow food, this flap falls down here. Okay? So that means the food comes in and now it can't enter the larynx. It only goes down the esophagus. Okay? This is like the uvula in the back of the throat is a little flap here that closes so that when food goes down, it doesn't somehow get up and into our nasal cavity. So too does the glottis come down and prevent food from getting into the larynx and into the trachea. So here's what it looks like. This is the false vocal cord. Yeah, so this is the tissue that holds on to the true vocal cords. And then when these tissues pull, the false pulls the true open. The opening is called the glottis. So here are our false chords, our true chords, and the glottis. Air comes up through the trachea into the larynx, passes through the glottis. The amount of air creates the volume. The tension and shape here creates the pitch. And then that further gets modulated through the pharynx, through the resonance chambers, that is our sinus, through the use of the tongue, through the pressing of the lips to create sound that we call language. All right, inferior to that, we have the trachea, which is also known as our windpipe. I don't care that you know how long it is. It's anterior to the esophagus and enters the thoracic cavity. So now we are entering the lower respiratory tract as we enter the thoracic cavity. It splits into the primary bronchi of the bronchi tree. And when it does so, it creates this little underwear, this whitey-tighty appearance called the carina. It's just a specific piece of cartilage. We just name it. The inner walls of the trachea is lined with ciliated mucous membranes. So remember, again, goblet cells. Okay, they produce mucus, traps incoming particles. Cilia sweep them towards the pharynx, up and into the pharynx, where it is then swallowed into the esophagus. So again, going back to that picture, if particles do get trapped in here, bacteria, whatever, mucus traps it, we cough, the mucus pushes back up, it goes out and down the esophagus into the stomach, where stomach acids kill it. The wall is supported by roughly 20 incomplete or C-shaped cartilaginous rings. All I need you to know is that the trachea, it's ciliated with a mucous membrane, contains goblet cells for mucus that push the pathogenic material into the esophagus. And yes, it's composed of C-shaped cartilage rings. And it looks like that. So if you were to turn this around, these would not connect. They're not full rings. They're in the shape of a C. So again, we have our thyroid, cricoid cartilage, the epiglottic cartilage behind there. That's the voice box of the larynx. Once we drop down into the trachea, we are in the lower respiratory tract. This little underwear thing, so imagine that's Superman's underwear, right? That's the carina. It then breaks down into the bronchial tree, so the bronchi. Yeah, these are our primary or main bronchi. Then it breaks off into the lobar bronchi, meaning the lobes, and you'll notice they break one into each lobe of the lung. These are also known as our secondary bronchi. And then finally into the segments of the lobes, the tiny tertiary bronchi. We can also see in this image, we can see the visceral pleura. Yeah, we can see the parietal pleura in the pleural cavity. So this is the serous membrane that protects the lungs. So visceral touches the organ itself, parietal touches the thoracic cavity, and the cavity is the space in between where the serous fluid is. I talked about in class that the heart has 3 valves on the right side, the tricuspid, and 2 valves on the left side, the bicuspid. So too does the lung have 3 lobes, superior lobe, middle lobe, inferior lobe on the right side, and on the left side, just a superior and inferior lobe, 2 lobes on the left side. The heart would be nestled in here with part of it going under here. If you rip open the thoracic cavity, most of the heart is not visible because the lung actually folds over it to help protect it. So the bronchial tree consists of branched mucous membrane lined tubular airways. Again, that's all to say that the bronchi just have mucus in them, and they all have the cilia, which again pushes things back up the pathways to be swallowed by the esophagus. The lungs at the end of the bronchial tree become the alveoli, which is the air sac where the lung actually gets stores the oxygen. So like I said, we have our main primary bronchi. That's our first branch off the bronchial tree. 1, 2. Then we have our lobar or lobe bronchi, secondary bronchi. It branches into each of the lobes. So 3 on the right, 2 on the left. And finally, the segmental or tertiary bronchi. These are many, many, many bronchi that then break into all the segments of each lobe. Once the bronchi terminate as the segmental or tertiary bronchi, they become bronchioles, which are yet smaller tubes that branch off of the segmental bronchi. So kind of like we talked about large, medium arteries and then arterioles, the bronchioles are just really, really small bronchi. These eventually continue to branch as the terminal bronchioles. Okay. This is the smallest bronchioles that transport air without actually dumping the air into the alveolar sac. Finally, after the terminal bronchioles, we have the respiratory bronchioles. This is a branch off the terminal bronchioles that at the end of which house the alveoli. That's where the gas exchange happens. So as we get to the alveoli, we have little alveolar ducts, which then connect into the alveolar sac, which is where then the alveoli exchanges the gas with the capillary system, the gas being oxygen and carbon dioxide. So again, trachea, primary or main bronchi, secondary or lobar bronchi, and then tertiary segmental bronchi. They become bronchioles, which terminate as terminal bronchioles, and then respiratory bronchioles, which have the alveolar ducts that then become the alveoli. The vessels of the lungs, which are the pulmonary artery here in blue, because remember it's oxygen poor because it's about to pick up oxygen from the lungs, and the pulmonary artery here in red because it now contains oxygen picked up from the lung, then have the pulmonary capillary system. So oxygen from the heart, from the right ventricle, comes down the pulmonary artery. The blood pressure triggers filtration of substances into the capillary system. The capillary system then uses simple diffusion with the alveolar sacs, which means simple diffusion, it goes down the gradient. So the higher concentration of oxygen here simply diffuses into the capillaries. The higher concentration of carbon dioxide in the capillaries simply diffuses into the alveolar sacs where it's then breathed out. The oxygen now in the capillary undergoes colloid osmotic pressure and basically osmotically diffuses into the pulmonary vein where it returns to the left atria to go through the rest of the cardiovascular system and pumped out into the system. This is just a histological image. The capillary are the vessels themselves. The alveoli are the empty space filled with air. So the cartilage is present in the trachea and the bronchi, but lessens in the small structures and is absent in the bronchioles. So it's cartilage makes up most of the trachea and the bronchi, but as it goes into the tertiary bronchi, it's less and less cartilage until it's absent in the bronchioles. As the cartilage lessens, smooth muscle increases. Remember, smooth muscle is involuntary. Breathing is involuntary. There are things we can do to actively breathe, but otherwise, breathing is involuntary. It has to be because we breathe while we're asleep, right? And then the structure continues to be smooth muscle until it enters the alveolar ducts, where then it becomes simple squamous epithelium. Much like vasodilation and vasoconstriction, we call it bronchodilation and bronchoconstriction in the lungs. So bronchodilation just increases the diameter of the bronchioles. This happens during our sympathetic fight or flight. So again, if you need to run or fight something, your bronchioles and bronchi will dilate so you get as much oxygen as needed, therefore as much oxygen into the blood, therefore as much energy. Otherwise, when you're in rest and digest, okay, you're just going to be in a neutral bronchial state. However, in conditions such as an allergic response or asthma, we might experience bronchoconstriction, where they constrict really tight and now it's hard to breathe. If you've ever had an asthma attack, it's equated to breathing through a straw, right? Same with an allergic response. A severe allergic reaction can actually stop you from breathing because it constricts so much you can't get air. Remember, the bronchial tree filters, warms, and humidifies the incoming air. It has mucous membranes that trap pathogenic material and kick it back up into the esophagus. The alveoli, like I said, is simple squamous epithelium. So starts mostly as cartilage in the trachea, the primary, secondary bronchi. By the tertiary bronchi, it's less cartilage, it's more smooth muscle. Then it's only smooth muscle as we are in the bronchioles, the terminal bronchioles, the respiratory bronchioles. And then once we hit the alveolar ducts and the alveolar sac, it's now just simple squamous epithelium. Again, here is the simple squamous epithelium of the alveolar sac. Air has now been breathed in. Pulmonary artery becomes the capillary. Simple diffusion into the capillaries. Carbon dioxide out into the alveolar sac to get breathed out. Oxygen into the capillary system to then become the pulmonary vein to return to the left atrium to go through the systemic circuit of the cardiovascular system. The lungs themselves, they're soft, they're spongy, cone-shaped organs. Remember, they're separated medially by the mediastinum, which contains the heart. And they are enclosed inferiorly by the diaphragm and then pretty circumferentially by the thoracic cavity. The lungs make up the majority of the space that is the thoracic cavity. Okay? All of the blood vessels and the primary bronchus that enter the lungs enter from the medial side. Nothing wraps along the outside of your lungs and enters there. They all enter from the medial side. This is a review of the serous membrane, the pleura. Remember, visceral pleura is on the part that's inside. It touches the lung. Parietal on the outer portion that touches the thoracic cavity. Serous fluid in between in the pleural cavity. Remember, serous or pleural cavity is an action or is a potential space, so it's where infection can happen. The right lung is larger than the left. Why? Because there's 3 lobes, superior, middle, and inferior. The left lung is a little bit smaller, only 2 lobes, superior and inferior. Left lung is by no means small, it's just slightly smaller. The lobar bronchus supplies each of the 5 lobes, so remember main primary bronchus, then secondary lobar, enter the lobes. Finally, the tertiary segmental bronchus enter the different sections of the lobes. Each lung contains the air passageways, the alveoli, nerve, blood vessels, lymphatic, all the same stuff. It's just saying there that they're the same, they're just slightly different anatomically. I'm not worried about that. There you go. Red slide, learn it. All right. So ventilation. When we're talking about breathing, we're talking about the movement of air from outside the body into the bronchial tree, into the alveoli, and back out again. It's composed of inspiration and expiration. So when you breathe in, you inhale, you inspire. When you exhale, you expire. So in inspiration, air moves from higher to lower pressure. It talks about atmospheric pressure here. What I want you to know is when you breathe in, you are not actually controlling the movement of air into your lungs. It feels that way. Take a deep breath, and what you're actually feeling your body do actively is not pulling air in. What you're feeling is the muscles of the rib cage expanding the rib cage, making room for the air. Atmospheric pressure then vacuums the air into your lungs, because atmospheric pressure, air moves from high to low pressure. So there's high pressure in the air outside of you than there is inside. So when you expand your thoracic cavity, when you expand your rib cage, and that space is increased, the air rushes in because the higher pressure wants to go to the lower pressure, and that expands your lungs. That's all this is saying. Yeah? So when pressure inside the lungs decreases below atmospheric pressure, i.e. when the thoracic cavity expands, air flows in from the atmosphere, causing the lungs to expand. This increases the volume of thoracic cavity, causing air pressure inside the lungs to decrease. All right. So when the muscles pull the thoracic cavity open, it expands the volume of the thoracic cavity, decreasing the air pressure, causing the air on the outside, which is higher, to move inside to the lower pressure, expanding the lungs. The diaphragm and the intercostal muscles are what expand the thoracic cavity. So muscle between the ribs and the diaphragm expand. The diaphragm lowers. The external intercostal muscles pull the ribs further apart. That increases the thoracic cavity volume, decreasing the air pressure, causing air to rush in. When the opposite happens, internal intercostals constrict and pull the ribs closer together. The diaphragm raises. That puts pressure on the thoracic cavity, increasing air pressure so that it rushes out of the lungs and into the atmosphere. So again, when we breathe, we don't pull air in and push air out. We expand and contract our thoracic cavity. The air pressure between the atmosphere and inside the lungs then does the rest. When we have a maximal or forced inspiration, which is a deep breath, it requires the contraction of other muscles. I want you to know these. The pectoralis minor, which is your small chest muscle. Sternocleidomastoid, which is your big neck muscle, attaches the sternum, the clavicle, and the mastoid, which is the skull, and the scalenes, which come off of your cervical vertebra and attach into your first and second rib. These muscles help pull further on the sternum, on the clavicle, and on the ribs to create even more thoracic cavity volume, to therefore decrease the air pressure even more, to bring in more air. So when you regularly breathe, it's just your intercostals, the external, and the diaphragm moving to expand. And when you maximally breathe, when you really suck in air, you're adding the pec minor, the SCM or sternocleidomastoid, and the scalenes. Now, when you're talking about the pleura, due to the surface tension between the pleura and the thoracic cavity, as the thoracic cavity expands, the pleura also expands, and this causes the lungs to expand. That creates room for the air to rush in. Surface tension, however, while it increases the volume of the lungs by pulling, the thoracic cavity pulls on the pleura pulls on the lung increase in size, the air rushes in. It creates extra stress on the alveoli, which would generally cause them to collapse. However, there is a lipoprotein called surfactant, which allows the alveoli to stay inflated and not collapse. All I want you to know here is surfactant stops the alveoli from collapsing when you breathe in. Okay? So breathing in uses the external intercostals and the diaphragm, unless it's a maximal inspiration or a deep breath. Then we add the pec minor, the sternocleidomastoid, and the scalenes. And the reason why the alveolar sacs don't collapse during all this surface tension is because of surfactant. That surface tension exists between the thoracic cavity, the pleura, and the lungs. So again, we have the thoracic cavity, we have the pleura, we have the lungs. The external intercostals pull out, the diaphragm drops. If it's a maximum inhale, we also have SCM coming here and here. We also have pec minor, which is attaching to the sternum, and the scalenes, which attaches into the ribs. All expand the rib cage. That pulls on the pleura, which pulls on the lungs, which expand the lungs. Air rushes in because there's now higher pressure outside than inside, and surfactant stops the alveolar sacs from collapsing so it can receive the air. When we breathe out, the diaphragm raises. If it was a maximum inhale, the SCM, the pec minor, and the scalenes turn off. And then the intercostals pull the ribs together as the external intercostals relax, the internal intercostals pull them together. That increases pressure here, pushing the air out, and then the contracture of that internal intercostals and the raising of the diaphragm cause the thoracic cavity to push on the pleura, to push on the lung, to decrease everything to its normal size. So again, normal inspiration, maximal inspiration, sternocleidomastoid, scalenes, pec minor. Sorry, I said the sternum, it attaches into the ribs. That's right. All pull up, yeah. All right. This is just a lot more ways of saying what we already said. Yeah. Normal expiration is passive. There's elastic recoil in the muscles, causing the external intercostals to pull the ribs apart, internal intercostals to then pull them back together. Surface tension increases and decreases the size of the thoracic cavity, the pleura, the lungs. Surfactant keeps the alveolar sac inflated, and oxygen, or rather air from the atmosphere, which is higher outside than inside, rushes in. During maximal forced expiration, however, oh, sorry, that was inspiration. So expiration is the reverse of that process, yeah? The passive recoil of those muscles then close down, constricting everything. The diaphragm, the external intercostals relax, and then the internal intercostals pull together. As the diaphragm recoils, we put pressure upwards. As the intercostals relax, we put pressure from the outside in, pushing the air out of the system because now there's more pressure inside than out, so the air leaves the body, and then everything returns to normal. During maximal forced expiration, the intercostal and the abdominal walls pull even more. Okay? So it's passive and normal, and then in maximal, when you're really pushing everything out, the intercostals, the abdominal wall muscles all constrict. So again, during normal, we have just a recoil, we have the turning off of the muscles, and then during maximal, the internal intercostals and the abdominal muscles all continue to squeeze and activate to fully push the air out. Okay, spirometry. So now that we've gotten through the anatomy portion and some of the physiology, we're going to talk about the measurements. This is going to be the stuff that's actually important when you are practicing, yeah? Because these are the kind of tests that you're going to read. So spirometry. Spiro meaning breathing, metry meaning measurement. So it's the study of the air volume that goes in and out of the lungs, okay? The machine that we use for this is a spirometer. It is a tube, kind of like a straw, that you breathe in and out of, yeah? The respiratory cycle is considered to be one inhale and one exhale. When we're using a spirometer, we have people, the patient, perform multiple respiratory cycles. So a breathe in and a breathe out is one cycle. And we take different measurements. There are 4 main measurements that we look for when we're looking at respiratory volumes. Know the definition of all of these. So tidal volume, that's the air that enters and leaves the lungs during one regular breath. So it's not your maximal breath. It's not your maximal inhale or exhale. It's just a natural in and out. That is your tidal volume. That is just normal breathing. The inspiratory reserve volume is the volume of air that can be inhaled in addition to the tidal volume. So that's just your forced inspiration. So again, when you breathe in and out normally, that's tidal volume. But for a second, breathe in normal, and now breathe in even more on top of that. That is your inspiratory reserve volume. So it's the reserved volume that could be further inflated in your lungs. The expiratory reserve volume is just the opposite. In a normal breathe in and out, you exhale some amount. The expiratory is your maximum expiration, the force maximal. So that's using the intercostals and the abdominal muscles. So breathe out, normal, and then really push it out. That is your ERV, yeah? The residual volume is the amount of air that remains in the lungs after maximal expiration. So when you breathe out as hard as you can, even when you go all the way where you can't go anymore, there is still some residual air inside your lungs. There is always air in your lungs as long as you're alive. Now, when we talk about respiratory capacities, it's a combination of two or more volumes. So the inspiratory capacity, or IC, is a volume of air that can be inhaled after a normal resting expiration. So what does that mean? So breathe out normally. Now, part of your tidal volume, which is your normal inhale, plus that maximal inhale, that inspiratory reserve volume, that is your inspiratory capacity, yeah? Which should make sense. If you breathe out naturally, the amount that you can breathe in naturally, adding to the amount that you can maximally breathe in, that's your total inspiratory capacity. That's how much total air you can breathe in, yeah? Now, the functional residual capacity is the volume of air that remains in the lungs after expiration. So, what does that mean? So, it's the residual volume plus the maximal expiratory reserve volume. So, it's the opposite of the inspiratory capacity. It's your functional residual capacity. So, once you exhale naturally, the amount that you can further force out plus what is then still left over is your functional reservoir, yeah, your functional residual capacity, FRC. Vital capacity, it's the maximum volume of air that can be exhaled after the maximum inspiration. So you breathe in as much as possible, and then everything you can breathe out, so that's your tidal volume, your inspiratory reserve volume, which is the part after you breathed all the way in, and the maximum that you can breathe out. So this is everything but the residual volume. Yeah? So taking a deep breath in, everything you can breathe out from that point on is your vital capacity. That is how much air you can maximally push out of your lungs, leaving only the residual volume left. Your total lung capacity is the total volume of air that the lungs can hold. Yeah? So it's your vital capacity plus your reservoir. Okay? So it's the total amount of oxygen or air that the lungs can hold. The anatomic dead space is the air remaining in the bronchial tree that never quite makes it into the lungs. Okay? So when we're talking about spirometry, I want you to know these four volumes: tidal volume, IRV, ERV, and residual volume. And then I want you to know these capacities. And what I'm going to ask is, what is it called, or what capacity is defined by the IRV plus the TV, right? Or the functional residual capacity is composed of the ERV plus the RV. And with all of these, I'm not just going to put letters. I'm going to put the total name plus the acronym. But that's how I could ask that. For anatomic dead space, just know that's the amount of air that stays in the bronchial tree that doesn't quite make it into the lungs. So this is a good chart to kind of show. Tidal volume. This is your normal in and out breathing. Yeah? Your inspiratory reserve volume is how much after your tidal inhale you can still continue to inhale. Yeah? Your expiratory reserve volume is after you exhale, how much more can you force to be exhaled? The residual volume is the part that's left over that you just cannot push hard enough to get the air out of. Understand, if you did have the ability to push all of the oxygen or air out of your lungs would literally have to like turn inside out, right? Because there's always going to be some thing left in the sac. So this is your tidal volume. That's your normal breathing in and out. This is how much more you can maximally inhale by force. This is how much you can maximally exhale by force. And then this is still what's left over. The vital capacity is how much you can totally inhale and exhale by force, but there's still that residual volume left over. Inspiratory capacity is how much you can inhale. Functional residual capacity is how much you can exhale plus what's left over after you exhale. And total lung capacity is everything. How much you can inhale, how much you can exhale, and what's left over after you exhale. There it is. Memorize it. I don't need you to know these volumes. Okay, not important. All right, non-respiratory movements. Don't get caught in the weeds with this. This is just air movement that's not used for breathing. Everything we've talked to now is about air moving through the lungs and the passageways designed for breathing, for bringing oxygen in, kicking carbon dioxide out so that we can create energy. Coughing is a reflex that clears substances from the lower respiratory tract. Again, pathogenic material gets into the respiratory tract, gets caught in the mucus, the cilium pushes it back up. Coughing helps to push it back up so that it can go into the esophagus, into the stomach, where the stomach acid kills the stuff. Sneezing is a reflex that clears the upper respiratory passage. So mucus in your nasal cavity with the cilium pushes the pathogenic material out towards the nostrils. The reflex causes you to sneeze, spewing all of that mucus and bacteria, pathogenic material out of your body. Laughing and crying. Laughing and crying causes rapid inspiration and expiration of air via a short burst. This is used to express an emotion. This is not designed to bring in oxygen and push out carbon dioxide. This is a part of our emotional center of the brain. Hiccups. Understand that they're a spasm of the diaphragm. Functionally, we're not really sure why this happens. Yawning. This is a reflex that is highly hypothesized to be a response to low oxygen. So if you're not breathing properly, you're more inclined to yawn. The old adage of you yawn because you're tired is BS. Yawning because you're tired in the sense of you're oxygen deprived and that makes you feel tired, yes, but not because you're bored. People don't yawn because they're bored. It's a reflex that when we see a yawn, we do a yawn. It's also theorized that it is a body's automatic response to force you to bring in oxygen if you're not breathing properly. So control of breathing. Let's talk about homeostasis and the receptor, the set point, and the effectors that cause us to change our breathing. So normal breathing is rhythmic and involuntary. We do not choose to breathe in and out. It naturally happens. It has to be that way or else we die every time we go to sleep. You breathe in your sleep because it's not voluntary. We can make it voluntary with our maximum inhale and our maximum exhale, but that regular tidal volume, that regular rhythmic breathing, that is not voluntary. Like our heart, it just happens. So it's composed of a group of neurons in the brain stems, the medulla oblongata, the pons. I don't care that you know that. I want you to know that it's in the brain and it's in the carotid sinus. It's similar to our blood pressure being controlled, okay? These areas control inhale and exhale as well as the rate and depth of breathing. So here's what I do want you to know. The medullary rhythmic center. This controls the rhythm of your breathing. The ventral group is your basic set breathing. That's your tidal volume. It stimulates the respiratory muscles and sets your basic rhythm of inhale, exhale. The dorsal group also stimulates these muscles, but it's involved in reflexes that control how fast and how deep you breathe. So the ventral group is the basic rhythm. The dorsal group is how deep and how rapidly you're breathing. The pontine respiratory group, that limits the duration of breathing, okay? So what does it mean? The pontine group and the medullary respiratory center. This is your how long you're going to be in a phase. This is your rhythm. This is your depth and frequency. They all work together. So this decides what the rhythm and depth is going to be. This tells the respiratory muscles to then do it. Yeah. So again, ventral group is the rhythm, dorsal group is the depth and rate. And that's all stimulated by the pontine. So when we talked about receptor set point effectors, remember with the skin it was thermoreceptors. With the blood pressure it was, and the heart rate, it was baroreceptors. With breathing, it's chemoreceptors. So chemoreceptors are areas in the brain that are the receptor point that detect the concentration, funny enough, not of oxygen. When we're talking about the reflex and the homeostasis of breathing, we're talking about the concentration of two things: carbon dioxide and protons, hydrogen ions. Remember, protons determine pH volume. The more protons, the lower the pH, the more acidic. The fewer protons, the higher the pH, the more basic. So, if the levels of carbon dioxide or protons get high, meaning we become acidic, then the chemoreceptors, which sense that change, send a signal to the set point, the respiratory center, which is the medullary and the pontine, which then causes breathing rate to increase. So if we have too much carbon dioxide, we need to breathe it out and breathe in more oxygen. So as carbon dioxide increases, so too does protons in the blood, causing a decrease in pH, causing it to become acidic. The chemoreceptors detect it. It sends a signal to the set point, which is the respiratory center, composed of the medullary center and the pontine center, which then tells you, hey, breathe more. That's the effector. The respiratory muscles are the effectors that increase breathing. As carbon dioxide is exhaled, the blood and cerebrospinal fluid levels fall and breathing returns to normal. Breathing rate will decrease if carbon dioxide or proton concentration decreases. Okay? So, what we're saying here is that if these things rise, it becomes acidic. It sends a signal to cause increased breathing. If carbon dioxide decreases or the blood becomes more basic, then a signal will be sent to the respiratory center to lower the breathing so that we're keeping some of our carbon dioxide and protons so as to make it more acidic. This is just saying that low oxygen in the blood does not affect the chemical receptors. And that should make sense because in the cardiovascular system, we are constantly shifting oxygen around the blood. So if we changed our breathing due to the prevalence of oxygen in the blood, we'd rapidly be increasing and decreasing our breathing all the time. So the reflex for how much you breathe is not based on oxygen, it's based on carbon dioxide. Now, oxygen can affect our breathing rates, but it has to be a big shift. It has to be approximately 50% of the normal amount or lower before oxygen will play a role in determining our breathing concentration and frequency, okay? So chemical receptors are in the brain. They're also in the peripheral system, in the carotid bodies and the aortic bodies. This is just where the baroreceptors also are. So there's a couple points where those sensors are, yeah? And the peripheral receptors do sense when the blood is hyper low in oxygen. And all that's saying is it transmits the impulse, which then determines the rate of breathing. All I want you to know is chemoreceptors are your receptors. The respiratory areas, the pontine and the medullary, are your set points. The respiratory muscles are your effectors. That's what I want you to know. If carbon dioxide increases, then it's going to detect it and send a signal to the brain saying decrease the breathing. If carbon dioxide decreases, then it's going to tell you to, or I'm sorry, if carbon dioxide increases, okay, where's that slide? Let's go back to it. Yeah. So if carbon dioxide increases, yeah, then we're going to increase our breathing. If carbon dioxide decreases, we're going to decrease our breathing. The only time we care about oxygen is if it's very, very low. This is just another way of saying all that. So if I'm not breathing enough, I start increasing how much carbon dioxide is in the arteries. This causes the pH in my blood to decrease. Chemical receptors sense this in the aortic and carotid bodies, and carbon dioxide increases in the blood plasma and cerebrospinal fluid, which all tell the respiratory center to tell the motor neurons in my spine to trigger the respiratory muscles to increase breathing. You don't need to know this whole thing. What I want you to know is decreased breathing increases carbon dioxide, decreases pH in the blood, causes the chemical receptors to tell the respiratory center to increase respiratory muscle usage so that we increase breathing. As we increase breathing, we decrease that carbon dioxide. That's the negative feedback. So if we're not breathing enough, we increase carbon dioxide and pH decreases, tells us to increase our breathing. We increase our breathing until carbon dioxide drops low enough, then we return to normal breathing. That's our negative feedback system. So, chemoreceptors are the receptors. This is the set point. This is the effectors. And then that increased breathing is the negative feedback to lower carbon dioxide. This is just also showing that these same changes then in the carotid sinuses go up to the brain and also tell the heart to do things. Remember, if we need to increase our breathing, we're going to increase our heart rate. We're going to increase our blood pressure. If we decrease our breathing, we decrease our blood pressure and our heart rate. So they function together. That's why this contains baroreceptors and chemoreceptors. That's why the medulla oblongata contains baroreceptors and chemoreceptors, because oxygen or respiratory and cardiovascular work together. All right, let's look at the reflexes of the actual heart. So the inflation reflex, this helps control the depth of breathing. Okay. And this is triggered by stretch receptors in the pleural membranes, the bronchioles, and the alveoli. All I want you to know is that the inflation reflex is a reflex so that when you're breathing in, you cannot continuously breathe in air forever. If you did that, you would eventually pop your lungs. So this reflex basically senses how much stretching is happening in the pleura, the bronchi, and the alveoli, and it stops you from breathing in too much. Try breathing in as hard and as long as you can. Eventually, you will stop. That is because of the inflation reflex. So when I talk about the inflation reflex, it is the reflex that stops you from popping your lungs, and it's because it detects how much stretch is on the tissue. So if the stretch becomes too much, it stops you from doing it. Others factors affecting breathing, emotion. I mean, that's self-explanatory. Just understand fear, pain, happiness, excitement. That all affects your breathing patterns. And it's not related to the amount of oxygen and carbon dioxide in the body. It's related to your feelings, okay? In the same way, your heart rate, when you're really excited or nervous, your heart rate changes. It's not a response to blood pressure and trying to get oxygen. It's your emotions. So, there is voluntary control of breathing, right? And that's what we talked about earlier with the maximum inhale and exhale. There's also a voluntary stopping of breathing. You can stop breathing for a short time. You cannot stop breathing forever. Even if you hold your breath as long as you can, that CO2 will build up in the blood and eventually you'll pass out, at which point your body will take over and that buildup of CO2 will then increase the pressure of CO2 in your arteries, decrease the pH in your blood, turn on the chemoreceptors to trigger increased breathing. So there's no such thing as totally stopping your breathing, just until you pass out. Hyperventilation. So taking quick in and out breaths lowers the amount of carbon dioxide in the blood. It can be used to increase breath holding time. So hyperventilation is just what we call it when we're breathing in and out very, very quickly. And it's related to breath control. So sometimes this is a meditative thing, yeah? So just be aware of these different things. The inflation reflex stops you from popping the lungs. Hyperventilation is a rapid inhale and exhale. You can voluntarily stop your breathing, but you will eventually pass out and breathe again. And then emotions can affect your breathing as well. All right, the alveoli. We already talked about this. They're microscopic air sacs. Okay, they're clustered at the end of the alveolar ducts. They are the only site of exchange of air between, or oxygen between the air we breathe in and the blood. So again, recap of the same image that we saw before. So the respiratory membrane, this is the anatomy where the gas exchange occurs. And it happens through rapid, simple diffusion. Simple diffusion happens down the gradient from high concentration to low. It does not require energy. The respiratory membrane is composed of the simple squamous epithelial cells of the alveoli, or the alveolus if we're talking about one, and the endothelial cells, which are also simple squamous, of the capillaries. Remember, both have to be simple squamous because simple squamous diffuses simply. The other part of this membrane is the fused basement membrane, the connective tissue between them. So, this is an alveolus, right? This is the membrane of the alveolus, the simple squamous cell membrane. This is the connective tissue that connects it to the capillary membrane, which is also simple squamous. Here's the lumen of the capillary, which contains the red blood cells, white blood cells, and platelets. The respiratory membrane is the membrane composed of the alveolus membrane, the connective tissue, and the capillary membrane. Yeah, so all simple squamous, alveolar membrane, capillary membrane, and then the basement membrane made up of fibers from the fibroblasts. Those three things, those three layers, is the respiratory membrane because that's where the gas exchange happens. So what happens? This is a lot of writing. What I want you to know is this. The mixture of gases in your lungs and in your capillaries is a mixture of oxygen and carbon dioxide. We call it a partial pressure because there's a total pressure. Part of it is oxygen, part of it's carbon dioxide. That's all it's saying. Don't worry about the math and numbers. I don't care. What I want you to know is that gas, the pressure of oxygen in here and the pressure of carbon dioxide in here. Higher oxygen, low oxygen. That means the oxygen simply diffuses from the alveolus into the capillary. High concentration of carbon dioxide, low concentration of carbon dioxide. Therefore, carbon dioxide simply diffuses into the alveolus to get breathed out. The oxygen gets brought into the blood to be carried to the tissues where it needs the oxygen for energy production. These gas exchanges happen simultaneously. So part of the pressure in here is oxygen, part that is traveling into the capillaries. Part of it in here is carbon dioxide that came from the capillaries. There's partial pressure here. Part of the pressure in the capillaries is oxygen that came from the alveolus, and part of it's the carbon dioxide that is going to travel to the alveolus. That's all this is saying. The way that it happens is simple diffusion. And things like the short distance, the surface area, The steeper pressure and the solubility of gases all help. So these are really close. So simple diffusion happens. There's a lot of O2 here, little here. That's a very steep difference. So simple diffusion happens. A lot of carbon dioxide here, little here. That's a steep difference. Simple diffusion happens. Because of surface area contact, look at all the space they have to contact. Simple diffusion happens at all those places. And then the solubility of gases. Oxygen and carbon dioxide are very soluble because they're very, very tiny. So they diffuse through here. That is all what this page is saying, okay? High oxygen, very little carbon dioxide. High carbon dioxide, very little oxygen. Oxygen, boom. Carbon dioxide, boom. Simple diffusion. This is the respiratory membrane. The alveolar membrane, the capillary membrane, the connective tissue. That's it. Just another picture. Alveolus has 104 millimeters of mercury worth of pressure of O2 versus 40. I don't care about the numbers. Higher, lower, oxygen goes in. Higher carbon dioxide, lower carbon dioxide goes out. That's what I want you to know. The transport. Respiratory gases like oxygen and carbon dioxide are transport mostly by being bound to molecules in the blood or dissolved in the plasma. So what's that mean? Let's talk about oxygen. 98% of oxygen is carried in the blood. So oxygen binds to the red blood cells, specifically a molecule called hemoglobin. When oxygen is on hemoglobin, we call it oxyhemoglobin. Very simple. The 2% remaining oxygen is just dissolved in the plasma. So it's just floating around in the watery substance called plasma. 98% of it is actually bound to a red blood cell. So each hemoglobin molecule on a blood vessel can bind up to 4 molecules of oxygen. You need to know that. For every hemoglobin in blood, it contains 4 oxygen. So oxyhemoglobin is hemoglobin that is bound to, or is oxygen that is bound to hemoglobin. How does the oxygen bind to the hemoglobin? It binds to iron atoms. That is important to know, but I want you to think of it like this. Think of a patient with iron deficiency anemia. The reason this is a problem in patients is because if you have low iron in your blood, you cannot carry oxygen in your body properly. So think of what the symptoms are of iron deficiency anemia. You get sick easily, right? Without oxygen, you can't make energy. Your immune system doesn't have the power to fight. You get really tired, right? Without oxygen, you can't make energy. Therefore, you can't feel energized. So if you're not having enough iron on your blood, it can't carry the right oxygen. So therefore, oxygen must bind to the iron. So hemoglobin is a macromolecule. It has iron as a component part. The oxygen binds to the iron. How many oxygen? 4 oxygen for every hemoglobin. Okay. When you are in the capillaries of the lungs, all the oxygen binding sites for hemoglobin are occupied. So once blood runs through the lungs, it is 100% saturated. Every hemoglobin has exactly 4 molecules of oxygen. After, however, the blood drops off oxygen into the tissues, you don't actually drop off all the oxygen. You only drop off 25%. 75% of the oxygen stays on the blood as a reserve. So even when the oxygen is going back to the body via the superior and inferior vena cava and the coronary sinus, when we call it oxygen poor, it's oxygen poor. It's not oxygen absent, okay? For every molecule of hemoglobin, there are 4 oxygens bound to it. And when the blood drops off oxygen at the tissues, it only drops off 1 of the 4. The rest of the 3 stay attached, okay? That's all that's saying. Now, what I want you to know down here is if you're lacking oxygen in your tissue, so if your tissue isn't getting enough oxygen, we call it hypoxia. Hypo meaning less, oxia meaning oxygen. less oxygen. So it's not double O, hypoxia, it's just hypoxia. Okay? So we have blood that just came from the lungs, right? So it goes through the capillary, oxygen diffuses into the blood, it binds to the blood vessel, to the hemoglobin, to the iron on the hemoglobin. For every hemoglobin, there are 4 oxygens. Now, in this picture, it makes it look like there's one hemoglobin. There's many, many, many hemoglobins in a blood vessel. But for every one hemoglobin, there's 4 oxygen. It goes into the tissue and then it drops off some oxygen into the tissue. But it only drops off one of the 4. Then it makes its way with oxygen reserves, hits the lungs again, picks up one more oxygen, runs it back, drops it off, and it repeats over and over and over again. Now let's talk about carbon dioxide. Carbon dioxide is a little different, where 98% of the oxygen bound to hemoglobin, to the iron in the blood, and 2% stayed in the plasma. Carbon dioxide has 3 options. Carbon dioxide that gets released from the cells and enters the blood and the capillaries. You don't need to know the percentages, but a small amount is dissolved in the plasma. A larger amount binds to that empty hemoglobin spot. Remember, the blood vessel, the hemoglobin, dropped off 1 oxygen to the tissue. It now has an empty site. Carbon dioxide can bind to that, and that becomes carbaminohemoglobin. The majority of carbon dioxide, however, stays in the blood plasma but reacts with the water in the plasma and becomes a bicarbonate ion. So carbon dioxide in the plasma is actually 77%. However, 70% of that reacts with water and it becomes this bicarbonate molecule plus a proton. Okay? That's all I want you to know there. Don't worry about the rest. Okay? Bicarbonate ions diffuse out of the red blood cell. The proton binds to the hemoglobin. And creates a buffer. Don't worry about that right now. Know that there are 3 destinies for carbon dioxide. The smallest amount is in the plasma. The second amount becomes carbaminohemoglobin and binds to the blood. The largest amount also stays in the plasma, but reacts with water and becomes bicarbonate. Then, when it's transferred into the lungs, once it reaches the lungs, the bicarbonate reacts with the proton again and becomes carbon dioxide and water again. Again, I don't need you to know that reaction. I just want you to know eventually the carbon dioxide that is bound to the hemoglobin breaks off, re-enters the plasma. This bicarbonate ion becomes carbon dioxide again, and then all the carbon dioxide that's now in the plasma enters the lungs so it can be exhaled. Okay? So, what's happening? When a red blood cell gets to the tissue in the capillaries, the oxyhemoglobin breaks off the oxygen. It leaves the red blood cell. Remember, 98% of the oxygen is here. Breaks off the oxygen, leaves the red blood cell, simply diffuses into the tissues. 2% of that oxygen just was hanging out in the plasma, also simply diffuses into the tissue. Meanwhile, 7% of the carbon dioxide that leaves the tissue and enters the capillary just stays floating carbon dioxide in the plasma. 23% of it enters the red blood cell, binds to that empty hemoglobin now, and becomes carbaminohemoglobin. 70% of it enters the plasma, enters the red blood cell, combines with water in the red blood cells, becomes bicarbonate ion. Then, when it gets to the lungs, the oxygen from the lungs, 98.5% apparently, enters the red blood cell, binds with the hemoglobin, becomes oxyhemoglobin. Remember, there was already 3 here in reserve. This one just picked up another one, so it had the total of 4. 1.5% roughly enters the plasma and stays there. Meanwhile, the bicarbonate ion reacts with a proton, turning into water and carbon dioxide that exits the red blood cells, simply diffuses into the lungs. Carbon dioxide in the plasma simply diffuses into the lungs, and carbon dioxide in the form of carbaminohemoglobin breaks off of the hemoglobin, exits the red blood cells, enters the lungs. All of it's exhaled. Know this. That's it. Respiratory is not horrible. Understand the pathway from the upper tract to the lower tract. Understand the component parts. Understand how that gas exchange is happening, specifically oxygen and carbon dioxide. Know your spirometry measurements. Not necessarily the values, but what each title means. So in other words, the capacity and the volumes. And then understand the reflexes in breathing. Personally, I don't think respiratory is as crazy as cardiovascular, especially because a lot of the same story is being told. But it gets tricky when you're talking about which direction things are going. Remember, once we're talking about the capillaries, it's all simple diffusion. From a concentration that's high to a concentration that's low, this is called down the gradient. That's what makes it simple diffusion and non-requiring of energy. That said, we do have a sub set up for this week's class. I will be uploading this, and then I will have the some practice questions ready for you guys and the sub to go over. Any big question you guys have, feel free to shoot me an email, but respiratory really isn't too bad. Cardiovascular is the beast in this exam, but even then, if you can tell the story of the blood and you can tell the story of the oxygen and carbon dioxide, you really do have the majority of the information mastered. Then it's just knowing the reflexes, knowing the homeostatic mechanisms of receptors, set point, and effectors, and then finally knowing your tests, right? The ECG and the spirometry. Knowing those things, that's going to get you there, okay? All right. For class next week, not this coming week, this will be the review, but for the week of the exam, make sure all of your Module 4 assignments are done. That's our respiratory unit. And then after the exam, we will start on the integumentary and muscular system. All right, thanks everyone.